Welcome to our session on community-initiated care, transforming the who, what, where, and how of our mental health and addiction workforce. My name is Dr. Ben Miller. I'm the president of Wellbeing Trust. We are a national foundation focused on advancing the mental, social, spiritual health of the nation. It is an honor to be with you today and to share the virtual stage with my colleagues, my esteemed colleagues that you can see here on the slide in front of you. Our topic is one that matters. It's one that we talk about a lot, but sometimes don't always have solutions for. It's around workforce, specifically how each of us show up to address issues of mental health and addiction, and how essential it is that we begin to think a little bit more creatively about how we pursue solutions to workforce. Slide, please. For the last 2 years, events from COVID-19, from fires to floods, there's been almost a daily inconceivable heights of trauma, grief, stress, and isolation for too many Americans. The harm from these acute illnesses, whether it be climate change or a virus, extend morbidity and recoveries. Deaths reverberate deep in communities, which impact us as individuals, our families, our friends, caretakers, and colleagues. This is our context. It's the one that we find ourselves in today. Our country is hurting, and it has been hurting for some time. Recent data show how worry and stress related to coronavirus still impacts about half of us, 47% of this country. While that's slightly down from where it was last year at this time, we're still hovering around the 50% mark in the United States. That's a lot of people. Next slide, please. But even before COVID, we had a major problem. During the 2010s, over 1 million Americans died from alcohol, drugs, and suicide. That decade saw persistent increases in alcohol and suicide deaths and exponential waves of overdose deaths from different types of drugs. The trends specific to drug overdose, alcohol deaths, and suicide continue to go in the wrong direction. And as you can see here on the slide of you, these data have been tracked since 1999. If you look at the last batch of data that was available from 2019, we saw increased rates in alcohol-induced and drug-induced death rates, which are skyrocketed from the year prior. There were two notable trends that we noticed in the 2019 data that I think are very important to note. One is the age-adjusted drug-induced death rates among Black Americans surpassed whites after many years of substantially lower rates. And two, while only a slight change, the suicide death rate was a little bit lower in 2019 than it was in 2018, which is the first time that's happened since 2004, 2005. But what this slide should tell you is that we are hurting as a nation, that each of these data points represents an individual, a family, a friend. Next slide, please. And in our hurt, in our pain, we seek out help. The US Census Bureau showed that while some 22.3 million Americans recently received counseling or therapy for mental health professionals, which is an increase from more than 5 million compared with late August last year, there was an even bigger jump in the number of Americans saying they need that kind of help but didn't get it. And sadly, not getting care, not getting help is an all too familiar problem for most people. Next slide, please. In reality, only about 1 in 10 people with substance use disorders receive treatment. And according to the Kaiser Family Foundation, 39% of American adults have delayed accessing healthcare because of concerns about cost. And 4 in 10 adults with insurance say they have trouble affording their deductible. So what happens if our assumptions about where care is delivered is wrong? What happens if the community, leveraging its relationships with clinicians, want those clinicians in places that they actually are? Next slide, please. Places like our homes, our schools, even barbershops. It seems a major opportunity for us to reimagine care. What happens if each of us were better equipped to intervene on issues of mental health? This is our moment. This is our time for us to be radical in how we rethink workforce. That is why Wellbeing Trust, alongside my partners here today, have partnered to really develop a plan for how to scale up these models of care, to look deeply into the evidence and put it forward in a way that the communities can use the interventions that are available to help in themselves and others. This is, in essence, a model of care that is in community, by community, and for community. So we're really glad you joined us today, and we look forward to being able to spend this time with you. Vikram, I will turn it over to you.
Thank you very much, Ben. Ben has presented the scale of the challenge facing the American mental health care system. He's also presented an audacious idea that each and every one of us in the community can be leveraged to provide mental health care. My talk will refer to the evidence behind this audacious idea and introduce the initiative that we at Harvard Medical School are partnering with the Wellbeing Trust and others in the US to reimagine mental health care. But first, next slide, please. Let me remind us all about the scale of the problem by quoting Tom Insel, the former director of the National Institute for Mental Health. His words speak for themselves. Perhaps unlike any other health condition affecting Americans, in spite of enormous resources, not only for research by the NIMH, but also by state and federal authorities for the delivery of mental health care, all the metrics that pertain to mental health and addiction outcomes in the US have worsened. And we saw that in Ben's slide on mortality due to suicide and addictions over the last decade. Youth suicide rates, for example, have risen by about 50% in the last decade. It seems that no matter how much money we throw at mental health care, the metrics only seem to be getting worse. Next. I want to also remind us all that the US already spends and has more mental health resources than virtually any other country in the world. For example, there are more mental health professionals, MDs, PhDs, and other specialists in New York State than in the whole of Africa. And so we need to ask the question, why are we as a wealthy country failing to address mental health needs, no matter how much we spend and how much we already have? On this slide, you can see my diagnostics of why we have failed. And I'm pretty sure that each of you will also share some of these and have some additional ideas. At the heart of these, of course, is a very narrow biomedical framing of mental health into disorders and supposedly normal mental health, so that care is contingent on a diagnosis and then leads to a mental health specialist provider, who, as we know, are very few in number and tend to work in very focused places in the country, typically urban areas. Where we have community resources, these are hardly ever supported. In fact, I would argue they're even disempowered. We don't really attend in our care programs the social determinants. We don't consider the life course approach, even though most mental health problems begin before adulthood. We don't have an attention to the needs of specific disadvantaged groups in the population. And of course, let's not forget the demand side barrier. People often do not view their emotional behavioral difficulties through a biomedical lens of mental and substance use disorders, and as a consequence, are often reluctant to seek help from mental health specialists. Next. This is the great challenge, not only in America, but around the world. Indeed, one could argue it's even more severe in low and middle income countries. About 10 years ago, the National Institutes for Mental Health launched the Grand Challenges in Global Mental Health Initiative, an initiative that sought to identify the leading research priorities, which, if addressed, could have a measurable and significant impact on the burden of mental health and addiction disorders around the world. This initiative identified a set of research questions, almost all of which were implementation questions. How can we do better with the knowledge we already have? And over the last decade, the NIMH, alongside many other research funders, have contributed well over $500 million of new research money to researchers and practitioners from around the world to address the grand challenges in global mental health. Next slide. Today, I can confidently tell you that thanks to this research, thanks to this innovation in global mental health, we know how to deliver clinical and preventive interventions in an affordable and acceptable way in any resource setting, including the one pictured on this slide in Zimbabwe, where there's barely 10 or 15 psychiatrists and maybe a few dozen other mental health professionals for a population of over 10 million people. This body of evidence has allowed us to completely reimagine what mental health care looks like, and this comes very close to Ben's vision. Next. We can think of the redefinition of mental health care, and of course I always include addictions when I think of mental health care, in 4 broad ways. First, what comprises mental health care? Here we see interventions that are very brief, that are focused on specific elements that are designed to achieve change in the mental health condition. We often see interventions that combine both clinical elements alongside social work elements, recognizing that social determinants most often coexist with mental health problems and can interrupt the pathway to recovery. Next. Where mental health care is delivered, pretty much where people are. I'm sure we've all heard that slogan, let's meet people where they are and not where we are as professionals. And this is, of course, the hallmark of global mental health practice. Interventions are delivered in schools, community centers, indeed in people's own homes. Next. Who is a mental health care provider? Well, pretty much anyone. Anyone who has a calling to be involved with care and is willing to undergo the training and the post-training quality assurance and support activities that are necessary for this kind of task sharing work. In my own work, for example, I've used lay people most often, but also community health workers. And finally, the how. Of course, this kind of scaling up must happen in partnership with and in coordination with the mental health and behavioral healthcare system in that local community, so that no one falls between the stools and there is a seamless pathway of referral, both up, as it were, from the community to the more specialized care services, but also down from specialized care to the community for continuing care. Next. So at the heart, of course, of our efforts here is to build the foundation of the pyramid of care, and that foundation is in the community, what we refer to as community-initiated care that can include both healthcare delivered by the frontline workers attached to the healthcare system, such as community health workers and peer support specialists, but as Ben reminded us, even beyond, through sectors beyond the health sector. Next. This evidence has transformed policy globally and nationally. Here you see examples of reports from the World Health Organization, the World Bank, and in one instance, a national government, that of India, which has embraced this evidence and called for a transformation of mental health care systems by investing resources and energy at the base of the pyramid. Next. In closing, and you're going to hear more about this initiative from my colleagues to follow, along with the Wellbeing Trust and other partners, Harvard Medical School has launched the Empower initiative. We're also implementing this in India simultaneously. Empower seeks to scale up mental health interventions by building the community-facing workforce using a suite of digital solutions for learning, mastering, and delivering evidence-based, quality-assured psychological interventions. Next. We harness 5 important opportunities. The first, that mental health is already now way up on the top of the list of politicians and policymakers around the world, partly fueled by the COVID pandemic. Second, we have demonstrated evidence that brief psychological intervention, sometimes as little as 2 or 3 sessions for drinking problems, are highly effective, and that non-specialist providers are very effective in delivering these interventions. Peer-to-peer models for supervision are effective for quality assurance, and excitingly, we now have a suite of digital tools that have been shown to be effective in training people, to getting them to the necessary competencies to deliver these evidence-based interventions, and digital tools for supervision and support of these frontline workers. And of course, access to technology is increasing globally. Next. So Empower is a suite of digital tools. You will see here the tools are organized around the 3 stages of career progression for any frontline worker, from learning a treatment using pretty standard learning management systems, to delivery of the treatment using new tools for supervision and support that allow quantifiable quality assessments of the therapy that is delivered, and ultimately to integrating this frontline care into the rest of the healthcare system, for example, by linking the provider quality outcome data with patient outcome data. Next. In closing, this is a vision of enabling the progression of careers from naive learners, lay people in the community, a whole range of other non-specialist providers, to become competent, in specific psychological interventions that are evidence-based, to then ultimately become certified or credentialed based on their experience and performance, and over time, to ultimately become an expert in that particular care model and then contribute to building capacity. As you can see here, therefore, there is an inbuilt system of sustainability of the providers. Next. In closing, we already know that the current system in America is not fit for purpose when it comes to achieving effective coverage of evidence-based interventions for mental health and substance use conditions at the population level, with very large numbers of people receiving no care at all. And if we had to think of quality care, that number increases even further. We know that the COVID pandemic has fueled a great increase in mental health needs. The current system is doomed if we rely on it alone. What we need is a transformed system which builds the foundation of caregiving at the level of the community. And we believe that we can achieve this by leveraging and harnessing the amazing opportunities that digital technologies afford us, and thus not only increasing the workforce dramatically, but also increasing the numbers of people who are helped dramatically. Thank you very much. I'll now hand over to Shekhar.
Thank you very much, Vikram, and thank you, Ben, for inviting me to join this important seminar. I currently work at the Harvard T.H. Chan School of Public Health, but I have spent more than 20 years of my professional life working for the World Health Organization based in Geneva. And today, I would like to share some experience from the global work that I have done in terms of the international commitments and also with the international experience in many other countries, hoping that that will be of some help to rethinking mental health and substance abuse services within America. Let's start with the Mental Health Action Plan of WHO, which was passed by all ministers of health in the World Health Assembly in 2013 and has now been extended to 2030. Its vision is a world in which mental health is valued, promoted, and protected. Mental disorders, along with substance abuse disorders, which are explicitly included, are prevented, and persons affected by these disorders are able to exercise the full range of human rights and to access high quality, culturally appropriate health and social care in a timely way to promote recovery. Recovery is the theme for this seminar, so it's important that it's included there in the WHO's vision, all in order to attain the highest possible level of health and participate fully in society and at work, free from stigmatization and discrimination. This vision has several elements which puts the focus for the care, which is health and social care, within the communities and by the communities. That will be the best way to realize this vision, and that was clearly initiated by WHO, and US is a signatory to this mental health action plan. So it is important that US follows this vision for mental health and substance abuse services. It's also important to mention that the 2013 United Nations Agenda for Sustainable Development has a very clear and explicit target, which is on promoting mental health and well-being. It's not saying providing services for people with mental disorders. It's talking about promoting mental health and well-being, which is possible for the entire range of people who may or may not be suffering from a mental or substance abuse disorder at this point of time. In fact, we see mental health as a dimension, with everybody there on this dimension at some point on this spectrum, and also with time changing the position. Some of us might be enjoying a positive mental health right now. Some of us might have mental distress or a mental or substance use disorder or a psychosocial disability. But promotion can be done for all of us, wherever we are on this dimension, along with prevention for people in mental distress, not going into mental disorder, remission if we happen to have a disorder, and recovery if we have a disability. And if we take mental health as a dimension, then the entire range of intervention, starting from promotion to prevention to remission and recovery, are best done within the community because it takes care of the entire dimension and not only for people who might have a recognized disorder at this point of time. I know that Vikram has shown this slide, but I would just wanted to come back to it to explain that the entire model for mental health and substance use disorder care is like a pyramid. And at the base, there is the community initiated care as well as the health promotion and other formal and informal ways of care, including the peer support, which are included here under informal services, or we could also say non-clinical services, which really connects to the other levels of services in primary care or specialist care, but are at the base of the pyramid. That means they should be available to everybody and they cost the lowest. So this is the cost-effective and logical model for care, which actually is not practiced in most countries, but it should be practiced because that's where we will start with the community care and if needed, go into a formal healthcare system and more formal clinical care. Let's talk about this informal or non-clinical mental health care. Which settings is it delivered in? It could be within people's homes. That's the best. But if not, they could be in the streets, especially for homeless people. I'm very aware that many of the people who spend time in the streets have a substance abuse or alcohol problem. This care could be in institutions like in prisons and jails, again, which houses, unfortunately, a very large number of people with mental health and substance use disorders. It can be in healthcare centers, but still being non-clinical. It can be in public places like places of worship, clubs, gyms, bars, even shops. And certainly in schools and workplaces, which are extension of the community. And this care can be delivered by a variety of people. It could be health volunteers, and from the global experience, one has many examples. It can be the ASHA healthcare volunteers and workers, for example, in India. It could be lady health visitors in Pakistan. It could be medical reserve corps in USA, actually. It could be community health outreach workers, which is present in many, many countries. It could be peer counselors, religious leaders and practitioners, teachers, workplace counselors, and certain trained professionals like bartenders, hair care professionals, and many others. So the point is that a very large variety of people who are based in the community can actually, with training and with some supervision, can deliver this kind of informal and non-clinical mental health care. Let's take some examples of such care within a diverse group of countries, some of them very poor. And this is not something which is very recent. This paper was published in 1998, which actually describes a randomized controlled trial of the impact of school mental health programs in rural Pakistan. And they very clearly demonstrated using a very good method that the school mental health program resulted in increased awareness of mental health issues in students, but also in the community compared to the controls. Take another example of the friendship bench, which Vikram also referred to. It started in one of the poorest countries in Africa, Zimbabwe, and by using very clear and systematic scientific methodology, they have proved that by providing care through trained grandmothers and other women, they can help a large number of people. And this help is clearly demonstrated using very systematic method and can last at least 6 months, possibly more. This kind of result, in some cases, is better than care by the professionals and at a very small cost and using the resources which are there right within the community. There are many examples in countries in Africa of mental health care by traditional healers. We know that trained psychiatrists and psychologists are very few in most of these African countries, but they rely upon traditional healers who, of course, are anyway dealing with the problems of mental health and substance abuse. But with training, they can provide actually some quality care. A large number of proportion of people anyway go to the traditional healers, and healers can play a large role in caring for at least common mental disorders. And with training, they can become much more efficient in screening clients who need referral and additional care. Of course, we also need to know that malpractices by traditional healers are also common, and there are some very bad examples actually of prayer camps in Ghana and some other situations. But if that is already happening, the best course is actually to train them and to support them in decreasing the harms and actually improving the services that they're providing. And there are some very good examples that can be followed there. In fact, traditional healers are also there in America. It's just that they're not part of the community's care models that we need to garner. Lastly, I would like to describe a Dementia Friendly Communities initiative in Japan and in many countries. We know that Japan's population is aging much faster than many other countries. And people with dementia often are not finding enough care either in their homes or in hospitals or institutions. So Japan started a very ambitious program in 2004 for training general population and volunteers on how to care for dementia, how to be more mindful of the needs of people with dementia. And so far, 11 million persons have been trained, and it's replicated in 55 other countries. It's one of the largest community-based programs for being friendly to people living with dementia. And this is something which can actually be replicated in many other settings, not only for people with dementia, but for people who might have a problem of drug use or alcohol use or other mental health conditions. The implications of all of this global experience for mental health and substance use care in US are very large. Community initiated and community led care can actually add value to the mental health ecosystem. Global experience can guide on what could work. Integration of community initiated care can decrease the pressure on clinical care. Community initiated care can also decrease the cost of mental health care, and certainly that can be of great help. However, we do know that there are many administrative and financing barriers for initiating that. Our task is to look at the benefits and make sure that these barriers are decreased and removed. Thank you very much, Ben, and I pass it on now to John.
Great, thank you very much, Shekhar. All right. So my name is John Nashlund, and I'm really pleased to be here. So thank you very much, Ben, for the invitation to join this panel today. And I'm going to build on the last two presentations and really talk a lot about this exciting collaboration that we have between the Empower program at Harvard and the Wellbeing Trust. So just building on Shekhar's presentation, so one of the biggest challenges is really, again, this limited access to evidence-based mental health care. And we know that there's considerable evidence showing that psychosocial interventions such as psychological treatments and other types of interventions at the community level are potent for addressing common mental health problems as well as substance use problems. But we know that access to these programs is virtually zero. And this includes in the United States. There's very, very low access to these programs. And this is really, this failure to actually deliver these programs and to do it well represents one of the biggest challenges for addressing mental health problems globally. And I'd like to conceptualize, what are the main barriers to actually making these psychosocial interventions available in community settings. And the reason I want to cover these, present these is this is really what we're trying to address through the Empower program and then also through our collaboration with Wellbeing Trust. So one of the key challenges is content. So many of these programs are highly academic. They come in thick manuals that are complex. They're not necessarily designed for the communities where they could have the greatest impact. Though we know they can be simplified and they can be delivered, as Shekhar demonstrated in several different examples. The supply issue, which you've heard come up a number of times, is really who's going to deliver these? There aren't enough people who are trained, and how are we going to find enough people to train to do this well? Which leads to the third point, which is quality. So even when someone is trained, it's critically important that they are receiving ongoing support, ongoing assistance with ensuring quality, even delivering some of these treatments, and it can be a very challenging task in itself and often requires additional support, such as managing individuals facing crisis or dealing with other complex situations in the community. So each of these are really critical to address in order to realize the success of delivering these programs in community settings. So this is where we see a tremendous opportunity. While these are barriers and challenges, this has also been really the foundation of our partnership with Wellbeing Trust and the Empower program to really take the community-initiated care model and to scale this up in settings in the United States. So you're going to see, this is probably the last pyramid for today, but I'm showing another pyramid, really, again, focusing on the bottom piece. So this is really the emphasis of our work, thinking of this informal community, thinking of where care can be delivered at the community level outside of the formal healthcare system. So really, I think this is, it's a very novel idea of really taking mental health care outside of the health system. So just to recap what exactly we mean by community-initiated care. So this builds on considerable evidence of task sharing. So we saw a number of examples presented from different countries in sub-Saharan Africa, also in South Asia, and a number of other places around the globe, really showing that you can train individuals who are not specialized clinicians to deliver treatments for mental health and substance use problems. And they can do this very effectively, and in some instances, achieve even superior outcomes because these are often individuals who are embedded within the community and understand the challenges their patients are facing. This is really a concept to make mental health care, to empower individuals to deliver mental health care in virtually any setting. So really thinking beyond the formal healthcare system and really thinking about how to train lay members of the community, really thinking broadly in our definition of who would be trained, and then also how to ensure ongoing support and acquisition of the necessary skills, the knowledge, and the competencies to be able to deliver these programs effectively for addressing mental health and substance use concerns. So some of the key approaches for the community-initiated care model. So as we saw in the last presentation, this really is along a spectrum. It can go anywhere from self-help programs, self-care type programs, to more broad public health type interventions, thinking of promotion and prevention, which can be highly effective for addressing issues around misconceptions about mental health, addressing stigma, helping people realize that they might need to seek help. This is also a major challenge. And then importantly, how to actually build capacity and skills of individuals to deliver these low intensity psychosocial interventions in really any settings. And we saw earlier, it could be in someone's home, could be really in locations outside in the community, in schools, in workplaces, in places of worship, really thinking broadly of where this can actually happen. So really our goal in this work is just trying to think about anyone who is in reach of the community-initiated care model is able to achieve the beneficial outcomes through flourishing across life domains and leading a fulfilling life. So really addressing the underlying mental health problems that, or substance use problems that prohibit someone from achieving their goals. So how are we going to get there? So that's really what I want to walk us through in the next few slides is how do we get from this broad concept, this idea, and into action? So we are using a process called theory of change, and this is really a rigorous and systematic approach to map the pathway going from the evidence. So we've talked a lot about the evidence of these programs work well, they work well across different settings, but then how do you actually translate that into practice and into a community setting where it will achieve the outcomes that are intended? So that's what this process involves. You really have to try to understand what are the steps to achieve that goal, who is needed, what are the barriers or facilitators that you'll encounter along the way? How do you overcome these different challenges? What resources are required? What are the short and long-term goals? And then what is the ultimate impact? Through the theory of change process, this is also an opportunity to work with a wide range of stakeholders. So engaging different members of the community, representatives of different organizations, representing different, different sectors of society, and really thinking about how to work with these individuals who are not typically at the table when thinking around mental health care. But how do you engage them in planning how such a program could be implemented within their communities with the shared goal of addressing mental health and substance use problems that we know are widespread. This also then will give us, this process gives us a roadmap to really think of the steps needed and then also the metrics that we want to identify. So the metrics are especially important because it's an opportunity to also move beyond traditional clinical metrics, which often don't mean a lot when we think of someone in the community. What does a PHQ-9 score or something like a other type of clinical screen, but thinking more of what are meaningful outcomes that have an impact on individuals, but then also are potentially more approachable and understandable. So just to briefly give an overview of the work so far, in our collaboration with the Wellbeing Trust, we've engaged 22 stakeholders representing 22 different organizations, really spanning a number of different disciplines. So thinking some are engaged in mental health services, but others are from advocacy, patient advocacy groups, even municipalities. So thinking of cities, faith-based organizations, recreation organizations, policymakers. So really trying to think broadly of who we could bring to the table to work with us and to work collaboratively around how to develop this theory of change and create this roadmap for how we'll get to our intended goal. We've held 2 workshops. These have been intensive sessions working closely with the different stakeholder groups, really to capture all of their feedback and insights around, focusing very closely on what are the resources, the infrastructure that's needed, and again, focus on the short and long-term outcomes. This has been an iterative process. It's gone through multiple iterations with our team and working collaboratively between the Harvard and Wellbeing Trust teams. Just to give a kind of a brief snapshot, that very complicated little diagram in the corner illustrates the very many different pathways, but really just to break it down into what it looks like. Again, it's going from this idea of taking evidence. We know there's a strong scientific base, but then how to get that into impact in the form of community-initiated care that can be easily accessible to individuals and delivered by people within communities to those who need the support, and all the steps in between. So again, highlighting the resources that are needed, the organizational and community readiness, so to adopt these different practices, and then the ongoing supervision, support, and infrastructure needed to ensure that the intended outcomes are achieved. There's also core guiding principles around the theory of change. So really, again, these have been reinforced and emphasized by the stakeholders we've been working with. But again, moving beyond the traditional medical model for addressing mental health care. And importantly, this doesn't mean that the medical model doesn't serve a role. It's actually to the contrary. Community-initiated care serves as an incredible opportunity to identify people early who then can be referred to the specialist providers to receive more care for more complex conditions that require that additional support. Really thinking of a wide range of mental illnesses, so going all the way from more mild, early forms of distress, all the way to more complex, severe or disabling mental illnesses or substance use disorders. And then also thinking of individuals with disability, a very key focus on equity and diversity, thinking of addressing mental health challenges across different age groups, race and ethnic groups, gender minorities, and really thinking of other individuals who may face disparate mental health outcomes. And then also ensuring that the programs are contextually appropriate to the context where they will be delivered. So this is just an overview of our next steps. So really thinking of finalizing this theory of change, working with the key stakeholders that we've engaged, meeting with them again to really get feedback on the current version of this roadmap, and then where the next steps are. Then from there, designing this curriculum for how to actually make this work within a setting, and then bringing this theory of change into action by scaling up the community-initiated care model in community settings in the US. And that is the ultimate goal of this work and this collaboration together. And I will turn it back to you, Ben, to wrap up.
Thanks, John. Thanks, Vikram. Thanks, Shekhar. This is amazing use of time, and thank you for your expertise and your passion in the space. Well, as you've heard, central to any meaningful redesign of healthcare is some inevitable discussion of our workforce. It's foundational, it's essential. You all probably have your own experiences and stories of not being able to find a clinician who can help. And just like our title suggests, we think we must reconsider how we are discussing workforce. Who is doing what, to whom, where, and at what cost? Since most policy solutions tend to focus on the supply of our workforce, community-initiated care is disruptive. It's a robust solution for countless problems, as you just heard. There is a different way to think about workforce, one that takes some of the burden off the traditional clinical system and allows for others to begin to assist with those critical health needs. So it's really about you. It's about equipping each of us with the skills necessary to take care of one another. The data supports this approach, and now it is here on us here in the US to bring this model to scale. So if you're interested in learning more, interested in joining us, please check out the website as seen on this slide. And again, major thanks to my colleagues here, and thanks to all of you for joining us today. Take care.